Today, here's a list of our participants. Today we're going to address the concept of cultural humility and offer ways to improve patient communication. We're also going to describe a family preparedness plan and welcoming healthcare protocols. Here's a list of our presenters today. The ICAAP staff is also available to answer questions and provide additional resources. So please feel free to reach out to us. You will find our contact information at the end of this, at the end of the webinar. So let's start off by introducing you to Arun, a 12-year-old boy of South Asian descent. He's in the office today for his 6th grade physical. Arun presents with a BMI of 91 and a PHQ-9 score of 11. Can you hear me? Okay. I have no disclosures to report. Sorry, I can't tell what you're looking at and what I'm looking at. One second. Oh, wrong direction. All right, sorry. So thank you for allowing me the opportunity to talk about trauma-informed care today. It's a very important framework for working with immigrant children and families. Again, I have no disclosures. Today, I'll be discussing what an optimal model of care looks like for children in immigrant families and how to enhance communication so that we can better care for our patients. I will also be providing suggestions on how to incorporate these into direct clinical care and offer ways to weave trauma-informed care into your everyday practice. Here is a snapshot of the complex web of relationship, identity, community, and safety that may be associated with being an immigrant. For this talk, by immigrant, I'm referring to a household in which at least one family member was not born in the US or did not grow up in the US. Migration itself challenges individuals and communities. It has significant social, economic, and health consequences and can impact the long-term development of children. Anti-immigrant discourse has created a climate of fear, and recent changes in policy, such as public charge, have reduced access to healthcare and other social services so vital to immigrant children, while at the same time, increased immigration enforcement, familial disruption, and chronic fear of separation have created ongoing toxic stress and damaging the mental health of children. And finally, we know that COVID-19 has disproportionately impacted immigrant communities where so many of our essential workers live. Dr. Julie Linton describes model care as being comprehensive, coordinated, continuous, and culturally and linguistically effective care that is housed in a quality medical home. Model policies and protocols should address a wide range of needs, everything from immigration enforcement related concerns to issues particular to subpopulations based on their unique stressors. Model care should also incorporate aspects of trauma-informed care. Can you all see my slides? Sorry, am I blocking? There we go. There is no singular definition for trauma-informed care. It's more like a lens or an approach to working with families. It's a shift in perspective from a strictly biomedical model to a biopsychosocial one. The 6 main principles of trauma-informed care address safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and finally, cultural, historical, and gender issues. Overall, practicing trauma-informed care requires an awareness of the impact of trauma on the lives of children. And it seeks to avoid re-traumatization by promoting patient voice and agency. Continuous model care is facilitated by building relationships with our patients and families. How you approach a patient and family depends on your ability to build rapport and your own comfort level. It's usually safe to give a family space to get to know you over time and allow them to tell you their story when they are ready, not rushing in with questions that may be sensitive or threatening. However, in her work, Dr. Elizabeth Dawson-Hahn at Seattle Children's proposes a different approach. She suggests incorporating a migration history into an interview, just as we would a social history. Asking about a migration story at the first visit as part of the introduction can effectively normalize it. For example, saying something like, "Welcome. Let me tell you about our clinic and myself. Here is my story," and then invite them to share theirs. Now, invite, not force, again. This actually may end up revealing information about their journeys, their country of origin, their circumstances for leaving, their culture and beliefs, and it may actually provide insight about family structures as well, family members who are here and those who were left behind. And please note, you don't want to elicit their trauma story directly, but rather just contextualizing it can be helpful by saying things like, "Many people have gone through similar difficulties in getting here." Oops, what just happened? Language is key to building relationships. Consider using health equity language. Use people first language. For example, rephrase Spanish-speaking mom to mom who prefers to speak Spanish. Shift your perspective from treating others as how I want to be treated, and instead treat others as they wish to be treated. Ask about preferred language. Don't just assume. Ask. Ask what a family speaks at home. Don't just start speaking Spanish based on a patient's last name. You may find out the hard way that some patients take offense to those kinds of assumptions. While commonality and language facilitate relationship, language barriers can harm it. Language barriers are associated with less health education, worse interpersonal care, and lower patient satisfaction. Having access to a clinic interpreter can close the gaps in care for patients who have limited English proficiency. And it is also the law. However, insurers do not pay for interpreter services, and interpreter lines are often inconvenient, awkward, and expensive. Now there are digital platforms that provide interpreter services on demand through your smartphone or tablet. These are low cost and you can access them via subscription or pay as you go models. And this is especially viable for smaller practices. And in addition, consider having providers and staff demonstrate certification for dual language competency before interacting with patients and families without interpreters. Extended visits are also very helpful. And finally, children and family members should not be used to interpret. Providing comprehensive care requires that we invest in our professional development. According to a 2017 survey of ACAAP AAP members, 1/3 felt that they were not prepared to work with children in immigrant families. There are a number of ways we can ensure that we are providing quality care to immigrant families, such as making sure we have appropriate knowledge base in global health and international health. And we can also use tools such as ethnomed.org to educate ourselves about countries of origin and things such as etiquette, food, religion, and traditional medical practices. Institutions should also support ongoing education for clinicians and staff. In addition, electronic health records can help stimulate flow, help streamline flow and integrate clinical support into routine care. Helpful clinical pathways can be built into EHRs. For example, specific order sets can remind us to consider screening for various types of anemias based on a country of origin and ethnicity. Catherine Yoon at Children's Hospital of Philadelphia put together epic tool sets specific to different refugee communities represented at that institution. Referral resources and translated educational material can also be built into EHRs and templates. In terms of validated tools, note rote translation through a search engine or phone app can lead to misunderstanding and leave out important information. Please consider using instead translated standardized pediatric questionnaires. We will have links to these in our toolkit. In terms of documentation, we advise that you refrain from documenting immigration status at all in the medical chart, and all staff members should be aware of this policy. Depending on the type of warrant or information requested, the law may not protect private health information of immigrants of undocumented status. For example, the medical chart of a child receiving federally funded insurance may be subpoenaed and could be harmful if it contains information about an undocumented caregiver. In 2018, the records of unaccompanied children receiving psychiatric care in government facilities were accessed by Department of Homeland Security and used against them in court. However, at the same time, in order to facilitate continuity of care and staff communication, some practices do utilize specific ICD-10 codes for transmitting information that may impact patient care. Keep in mind, however, it's not very difficult to decipher the meaning behind such codes, so they're not altogether foolproof. From working with caregiver-child dyads, we know that the well-being of the child depends on the stability and well-being of their caregivers, which is why access to care, to mental health services and social service supports is so important. Families are more likely to access these services when they are recommended by trusted providers who are able to facilitate the warm handoff. It's so helpful to have multidisciplinary services all available under one roof. It improves follow-through on referrals and increases the likelihood that families will get linkages they need. It's also a matter of trust. Families may not feel comfortable walking into an unfamiliar law office and being asked about their immigration status. In addition to integrated services, consider working with health navigators. They can orient and assist newcomers through our complicated health system. Working with cultural navigators can also help us understand the nuances and different ethnic groups or communities. If you work in a larger institution, think about hyperlocally considering supports by partnering with community clinics and community-based practices. Isolation can be devastating. Ways to promote belonging and connectedness include introducing families to community resources, faith-based organizations, and cultural organizations that offer social support, mentorship, and nurture a positive cultural identity. Connect families with people who will help them continue their cultural celebrations and traditions. Everyone has a role to play in a trauma-informed responsive services. You don't have to be a therapist to be therapeutic. Multidisciplinary teams should include interpreters, health and cultural navigators, and social workers whenever possible. Everyone needs to be trained, including front desk staff. It helps if we can level the playing field and lower the power differentials between patients, doctors, and staff members. Letters of support offer one way of engaging in collaboration with your patients. Families may request a letter of support for caregivers who are in immigration proceedings, such as for removal or other immigration visas. Families will usually ask for the letter at the request of their attorney, and it's best to consult with the attorney as to what to include. Generally speaking, you should document how deportation of a caregiver would interrupt or be detrimental to the child receiving healthcare, and how it might harm them physically, emotionally, and psychologically if their parent cannot participate in their care. Document the psychological distress being caused by the threat of deportation, and affirm that it's in the child's best interest to maintain continuity of medical or psychological care with their current providers. If appropriate, you may also document the need for specialized care and the harm of sending a child to a location where adequate services may not be available. We all play an essential role in supporting the health and well-being of children in immigrant families. Our ability to do so depends on respect, communication, and cooperation. Respect is conveyed by using a trauma-informed approach, and communication can be enhanced via language services and ongoing education for clinicians and staff. And finally, cooperation requires implementing user-friendly clinic flow, which includes established protocols, referral systems, and built-in resources for medical documentation and patient education. These are all ways that we can improve access to care for children in immigrant families. Thank you, and I look forward to your questions and comments at the end.
Thank you, Dr. Giri. So up next, we have Dr. Rawan AlHeresh with a presentation on cultural humility and health literacy.
Can you all see my screen? Yeah, okay. Good morning, everyone. Thank you for offering me the chance to speak to you today about cultural humility and health literacy. My name is Rawan AlHeresh, and I'm an associate professor at Massachusetts General Hospital in Boston. To begin with, I have no disclosures to declare. Today, I'll be speaking to you a little bit about implicit and explicit bias and cultural humility and what we can do about our biases. And then I will talk about health literacy and communication with specific strategies to increase health literacy with the clientele that we see, including immigrant families. To begin with, let's start off by watching a video. Let's see. Are you able to still see my video screen? Can you see my screen? The video screen?
It's in presenter view.
It's in presenter view. Okay.
Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his lordship's scones below stairs, sir.
Why, I was planting my petunias in the potting shed.
Constable, arrest Lady Smythe.
But how did you know?
Madam, as any horticulturist will tell you, one does not plant petunias until May is out. Take her away.
Sorry, madam.
It's just a matter of observation. The real question is, how observant were you?
Action.
Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his lordship's scones below stairs, sir.
Why, I was planting my petunias in the potting shed.
Constable, arrest Lady Smythe.
Okay, so how did you guys do? Can you please put in the chat what you, if you did well, did you capture the 21 changes or not? Nothing at all. Okay. Are you still able to see my presenter view, or can you see the whole screen now?
Presenter view still.
Still? Okay. How about now? Okay, perfect. Okay, so I can see that the majority of you weren't able to catch the differences. And were you surprised at all? I was really surprised when I first saw this video. And the point that I am trying to make, or this video is trying to capture here, is that we tend to not see things that we're not looking for. And we are always at risk of missing very important information as healthcare practitioners when we are in our busy healthcare settings. So we always hear about people doing multitasking. So multitasking is actually a myth activity. And what we tend to do is to try to shift to task switching between two different things, so move from one task to the other. So the ability of a human being to do more than one thing at the same time isn't actually biologically, we're not capable biologically of doing that. So many of us believe that multitasking is actually true, when in fact it's not. With the busy hospital settings and the increased patient load, with the documentation that we have to do, and the environmental demands of the clinicians of the United States specifically, we have greater tendency to rely on cognitive shortcuts that our brain taught us as survival mechanisms. So this makes us more prone to execute errors related to attribution of specific groups, such as cultural groups and refugees and immigrants. And it also makes us more prone to bias and stereotyping, not because we want to display these things, but as biological creatures, this is what our brain defaults to doing when we are extremely busy and when we are in high demand situations that require a lot of energy from us. So again, as biological creatures, we tend to rely on our default experiences that we grew up with. So this leads us to think about two different types of biases that we have, which is explicit and implicit biases. You might have heard some of these terms before. So the first thing is, what is the difference between them and why is it important? We also hear a lot of people saying, I'm colorblind, I don't see color, I treat everyone the same, we're all humans. But these are all very, very important things that we need to consider, because this mentality is not going to assist us to move forward to be inclusive in our healthcare, especially to people of color and including immigrants and refugee families. So going back to the difference between explicit and implicit bias, explicit from its word is usually the actions and behaviors that we can see and we can hear. And implicits are the ones that our brains tend to default to when we are in these stressful situations that we just spoke about. Many studies have been published over the past decade, which clearly showcase that implicit bias, physicians and healthcare practitioners showcase this bias, and it reduces the quality of care. And for example, in one study that was published in the American Journal of Public Health showed that physicians' recommendations vary by patient race. And they found that African-American patients were less likely than whites to be recommended for cardiac revascularization at a public hospital. So just, having that mentality is, I think, extremely important for us, to be aware of if we want to improve our patient care, because it's just natural and it's humanistic of us to always default on what we know, which is sometimes the biases that we perform as implicit ones. So what can we do about our implicit biases? I think the most important thing here is that we need to educate ourselves about the biases that we have. So there are certain tests, such as the implicit association tests, the IAT tests that you can take. These will be, the link to some of these tests will be given to you in the toolkit that will be disseminated towards the end of this workshop. And you can start by taking a few of these tests in order to understand the biases that you have. And let me tell you, these biases, they change with time, and it doesn't necessarily, mean that if you do have, a bias that you're a bad person. I'm an occupational therapist by training, and I have a strong implicit bias against people with disabilities. And these are the people that I see every single day. And had I not known that, and had I not watched the way that I deal with people with disabilities, I would have been in the dark, and I wouldn't have had the chance to improve on the client care that I see, because the whole point of doing this is to try to limit any type of disparities that we might cause as healthcare practitioners, because we want our clients and our patients to come back to our practices. So the first key here is to be self-aware. So I encourage you to go and take some of the IAT tests to know what your biases are. So after you do your tests, you have to basically look in your circle. So look into your circle of family, look into your circle of close friends. Do you have people where you have strong biases against in your close circle? Do you have people of color? Do you have people who are, for instance, old, young, people who are obese, people who are Muslims, people who are Jewish, like these different groups of people? You want to make sure, if you have a strong association or a strong implicit bias towards one of these groups, you want to make sure that you have them within your close circle, so you can start to dismantle these association errors that our brains force or help make us default to in these stressful situations. And the other thing that we can do is to work on our communication and our health literacy. We know that implicit bias affects judgment, such as diagnosis and such as therapeutic decisions, as well as behaviors. So for example, how close you choose to sit next to a client and how often you make eye contact. These are very subtle things that make such a huge difference in getting the patient come back to your clinic. And if implicit biases are left unchecked, this, as I said, reinforces existing healthcare inequities and disparities, which lead to usually worse treatment outcomes. So what can we do? We heard these terms, cultural competency and cultural humility, multiple times. And what competence is basically an endpoint. And when we say that an organization is culturally competent, it's usually, you know, in the form of developing trainings, and it's developing to, you know, positive attitudes towards cultural differences, gaining knowledge in different cultural practices and worldviews, and developing skills in communication interactions within specific cultures. So if you joined like an organization and you know, in the beginning, usually what they include in like training and in orientation material are cultural competency modules, like how to deal with a Muslim patient, for example. And I'll just give you an example. Some of these culturally competent workshops say, like, you shouldn't try to touch a Muslim woman or shake hands with a Muslim woman if you are a male. This further emphasizes the stereotypes that we're trying to eradicate. So sometimes cultural competent care isn't the goal that we're trying to get to, because it further emphasizes the stereotypes of specific cultural groups. What we want is to be cultural sensitive, to be culturally, to have cultural humility. And basically, this attitude means that we have a lifelong commitment to self-evaluation, self-critique, learning, and recognizing the power dynamics and imbalances, and have a true desire to fix these power imbalances and to develop partnerships with people, including our clients who could be families of refugees and immigrants, and with people and groups who advocate to others for institutional accountability. So my invitation here is for you to think about how can we move our organization to be to reach the level of cultural humility as opposed to a cultural competent care. Health literacy is a very important aspect that we can, you know, work on. So what does health literacy mean for you as a clinician? It basically means the capacity of professionals and institutions to provide access to information and support the active engagement of people. And I want you to just think about how complex healthcare activities are. Sometimes we just don't sit and think about the different multi-steps that people have to do in order to complete only one task the physician or the nurse or the dentist ask them to do. So for example, think about the tasks that the individual has to do to complete taking medicine as prescribed. First of all, they have to find a pharmacy, they have to discuss medication with the pharmacist, then sign a form, find the name of the medication on the label, follow the directions, construct reminders, know which side effects to watch for, And this is only one task that we ask of our clients. If we have issues with one of these steps, imagine the ripple effect that will happen, and the client won't be able to complete all of these tasks in order to get to complete the tasks that we want. Add another layer to that if there is a language and a cultural barrier. So you have to be as clear as possible and as simple as possible in giving your directions and ensuring that your clients, including ones of immigrant families and refugees, get the healthcare steps as clear as possible. So I want to show you this really quick video here, and hopefully I don't have the same technical issues that I had.
Hello, Nadira. I'm Dr. Calais. I'm filling in for Dr. Smith. Looks like you had a very successful surgery last month. How's your recovery been?
Well, thank you.
I'd like to begin by doing a quick examination of the location of your surgical wound just to make sure you're healing correctly and everything looks healthy. May I ask you to remove your head covering?
No, I cannot remove my hijab.
Nadira, I want to make sure that you're healing from your surgery correctly, and in order to do that, I need to take a look. Did Dr. Smith not tell you this would be part of the follow-up?
Well, Dr. Smith is a woman, and you are a man, and I cannot remove my hijab in the presence of a man who is not my husband. or if that is why I came here, to see Dr. Smith. She can be the only one to do my examination. If Dr. Smith cannot be here today, I will have to reschedule my appointment.
All right. Why don't you wait here a moment, and I will check and see if she's on her way.
Okay, so what I wanted to show in this video here is that culturally, health literacy isn't only from the client's side, but it's also from the health practitioner's side. So we have to be, we have to be able to understand the nuances of specific cultures in order to give, the culturally, sensitive care, including improving the health literacy rates that we have as practitioners. I'm going to try to share my screen again, just one moment. Okay, sorry. Okay, so the factors that influence our low health literacy rates are basically incomplete information that we have about our clients, like you saw in the video just a moment ago. The fact that we didn't know, that the physician didn't know that that client has a preference to a specific healthcare provider's gender, that influences the health literacy rates. The second thing is the use of jargon. We want to make sure that we are always using simple language when we are communicating with our clients. The third thing is imprecise instructions, and also giving too much information. Sometimes we give, for us, we leave our physician's office with papers and papers of instructions, information about the visit, and it's just very difficult for the person to digest. You have to make sure that you are giving little information that are precise, and you focus on the most important aspects of the conversation in your conversation with your clients. And as Minal said in the previous section, the complexity of our healthcare systems make it very difficult to reach the health literacy rates that we want in our communication with our clients. So ensure that basically we are breaking down the system into digestible and more manageable steps so people can understand and become more health literate. And again, the lack of culturally and linguistically appropriate services always influences the health literacy rates that we have. So what are the outcomes of low health literacy? If all of these aspects happen, the ones that we just spoke about, usually this leads to less preventative use of services, lower rates of adherence to treatment, lower rates of referral and follow-up, and higher rates of hospitalization, and eventually higher healthcare costs. And what can we do about it? Again, self-awareness, self-reflection, and they are key in overcoming the biases and as individuals, and we can contribute to making some of this change in order for us to understand how we can attract our clientele to come back into our clinics. So again, awareness is key, and practicing and expanding our circles, and working on our communication and health literacy skills. I'm going to give you two specific strategies on how to improve our communication skills. So first, you have to address patient cultural values specific to the contents of their healthcare. So for example, ask questions like, is there anything I should know about your culture, beliefs, or religious practices that would help me take better care of you? So always make it about them as opposed to what you think they should be doing. Because healthcare in the end, it's an agreement between the healthcare practitioner and the client, and you want to come to middle grounds so you can ensure that they take what is important from what you're trying to tell them, but they have a tendency to generalize it and use it in their life. Another question we can ask, do you have any dietary restrictions that we should consider as we develop your plan to help you lose weight? Or, your condition is very serious. Is there anyone else that you would like me to talk about your condition, for example? Or what do you call your illness? Or what do you think caused it? These are all very important questions that we can ask and shift how we are talking with our clients. Again, it's very important to use very plain language. We have to use everyday language, preferably at the 5th grade reading level, and we have to use clear communication so the general public can understand. We have to explain necessary technical terms, and don't think that the terms that you know, everyone knows. We have to break things down to the simplest technical terms that we can think of, and explain the importance of information, avoid extra information. And one of the techniques that I always encourage people to use is using the teach back method. So let's say you give someone instructions on how to use a medication or a technique. So basically here, what you do is you demonstrate what the client is supposed to do and then ask them to repeat it to you or teach you how to do it to ensure that they understood all of the steps. And just make sure that this is not a test of the patient's knowledge, but it's also a test for you and how you were able to communicate all of these terms in lay language to the best of your ability. I encourage you to start thinking of things like this moving forward. And remember that at the end, it's all about perspective. And it's all about shifting the perspective to the client's side to meet them in the middle, as opposed to enforcing what you think should happen in your clinical practice. And with this slide, I get to the end of my talk, and now I will pass on the mic to my colleague, Mark.
Thank you, and I'll just bring up my presentation here. Hi, everybody. I'm Mark Kuczewski. I'm here to talk to you about the sanctuary doctrine approach to addressing the needs of your immigrant patients. This approach was developed in conjunction with two physicians, Johanna Matthias Beck and Dr. Amy Blair. I'm sorry, I didn't start the sound with that. Hi, everybody. I'm Mark Kuczewski. I'm here to talk to you about the sanctuary doctrine approach to addressing the needs of your immigrant patients. This approach was developed in conjunction with two physicians, Johanna Matthias Beck and Dr. Amy Blair. I am Mark Kuczewski. I'm a professor of medical ethics at the Loyola University Chicago Stritch School of Medicine, and I have no relevant financial relationships to disclose in regard to this presentation. I want to talk a little about who undocumented immigrant patients are and why consider discussing immigration-related issues with them, and a little bit about the approach that we're going to be taking today called the sanctuary doctrine approach. We're going to outline the communication goals of the approach and also give you some pointers to achieve those goals. I would like to invite you to come to the Sanctuary Doctoring website at luc.edu/sanctuarydoctor. We have a variety of free resources there that I'm talking about today. Who are our undocumented immigrant patients? Well, they've been here a while. 10 to 12 million of them reside in the U.S., and about 430,000, almost 500,000 here in the state of Illinois, a high prevalence state. They've been here, as I said, 2/3 of them have been in the U.S. more than 10 years, so they're integrated into our communities. They're our neighbors. They're people we should serve. The stereotype is that they are all Latinx patients. That's not true. The most sizable group are people who originated in Mexico or of Mexican descent, but that's a little less than half of the pool these days. As immigration patterns in the United States have shifted so that most of our immigrants are coming here from Asian nations, that is also where the pool of undocumented patients are growing, because they often originate with visas, are unable to renew them, or they expire and they can't adjust their status, and they remain in the United States. So in the state of Illinois, 27% are from Asia or Africa or the European continents. They're typically pretty young. 3.2 million are under the age of 24. 72,000 people in Illinois fit that description of being undocumented and under 24. 2 million actually fit the description of the United States of being minors, that is under the age of 18. 20,000 are under the age of 18 approximately in the state of Illinois. But as you can see, that means that there's a lot of people in that 18 to 24-year-old range, and that's because they've been here a long time. So many have grown up here. About a third of undocumented children lack health insurance, and that creates its own set of problems. In addition, there are about 4 million people who were born in the US, that is, US citizens, who are the children of undocumented immigrants. And so, of course, their parent status can also affect them. And that's a key point, that undocumented youth, pediatric patients, do have direct stressors from their immigration status that affect them. But also the status of their parents can create stress and affect them. It has been shown that, in fact, the immigration-related stress of mothers does directly impact children. And so we have to address the needs of the whole family in regard to immigration status. Again, I invite you to come to the Sanctuary Doctoring website, and you see a demonstration video there of how to talk to patients. But the goals are really to open this dialogue about immigration-related stress, provide them reassurance, provide them some concrete resources, and then begin to develop an emergency plan, which you'll hear a lot more about from our next speaker, Laura Hoover, but I'll get us started a little bit. And this program really enables you to do this within about 10 minutes of a clinic visit. The first objective is to open the dialogue, and that's probably the single hardest thing, because you also don't want to scare the patient. The patient may bring it up directly. If you use these Sanctuary Doctoring flyers, which I'll be talking about in a moment, leave them out in your clinic, particularly in the exam rooms. The patients like to look at such materials in the exam rooms when they're alone privately. We found if we put them in the patient exam rooms, they fly off the shelves. If they sit out in the common waiting area near the front of the clinic, patients don't often pick them up because they're afraid of self-identifying as undocumented just by picking up the brochure. But the brochure will prompt them to raise these stressors with you. We'll talk about that in a moment. You then also want to reassure them that this is because this is something that's very common, that they're not alone. When we have a problem, we think we're the only person who has it. So you want to tell them that many of your patients are currently experiencing these same things. And they may even choose to talk about this in relation to others in the family. The child may talk about their parent. The parent may talk about a child or a spouse or another family member. Or they may choose to talk about themselves in code by saying that. So asking them, are you or your family or friends having these kind of problems, can prompt dialogue. Here's the cover of the Sanctuary Doctoring flyer. And again, you can download the templates free of charge and use them from the Sanctuary Doctoring site. And it explains that their immigration problems can affect their health status and that they can talk to their physician about these concerns. And we have in bold right on the cover that if they want to talk about these concerns, they don't even have to say anything. They can just hand you the flyer. And so that's one easy way to open the dialogue. Again, once you've opened the dialogue, you want to keep providing reassurance. Some of that is of the nature that they're worried that you're going to write things down that could get them in trouble. So you want to tell them you won't write anything about their immigration status in the medical record. You will only record health-related issues. And of course, you want to make it seem like you're not just being a little bit nosy, but that you have a reason for this. This kind of anxiety impacts their health. They're free to express these concerns here. And again, keep going back to the idea that this isn't unique to them. Many people are going through these things. Again, a little bit about the brochure, which essentially pledges to the patients. You write your name of the clinic in there, that clinic, they are safe to express these things. You won't record anything in the medical record about their immigration status, and that you'll work with them to reduce that stress and get them resources. In the flyer, we recommend a couple of things. One, that undocumented youth, sometimes called dreamers, that term's fading a little bit, but it's pretty encoded in a lot of organizations, names like United We Dream, that undocumented youth join some of these organizations and get on the email lists and or join them on Facebook groups or things like that, because there are a couple of reasons. One, they need to keep up with new information. As you may know, Deferred Action for Childhood Arrivals, or DACA, which grants them a 2-year stay on their immigration status and also a work permit, has really evolved a lot in the last 4 years, from the Trump administration trying to rescind it in 2017 and closing it to all new applicants, to having judges keep it open for renewals during the last 3 years, to then the Supreme Court striking down the Trump administration's action and not only keeping it open for renewals, but allowing new applicants to apply for DACA. All this keeps changing. How can a young person keep up with that? Well, the easiest way to do is to be on the mailing list of something like some group like United We Dream, and so you get the email that tells you what's going on. And also, undocumented youth are not eligible for federal student loans and have difficulty of financing higher education as a result. There are scholarships available to them, private ones, and educational opportunities available, and they need to be able to navigate them. And so connecting with various kinds of networks can really help with that. And similarly, the flyer also talks about legal resources, which again, you'll hear a lot more about in the next presentation from Laura Hoover. But the template for the flyer lists some national resources, and you can add some of your local ones. Again, national resources on the Dreamer networks, United We Dream being the best, but then also scholarship organizations like Scholarships AZ and Educators for Fair Consideration often compile lists of scholarships and available opportunities. And of course, the U.S. Department of Education also has some information on its website. But we invite you also to put in local resources. And so in our flyer, you'll see an example of one filled out for our local area here in Chicago on the website. And we have ICER has some great information about education initiatives, but then various universities, particularly the Catholic universities in town, have devoted significant resources to undocumented youth, and visiting their web pages can provide a lot of information. And so here you see side by side the template on the left for legal resources, in which we tell people that they should get Know Your Rights training. And because it's fearsome to go into something that's advertised as Know Your Rights training, you can get it online these days. And so we show some national resources for online Know Your Rights training, the ACLU, the NIJC, and then invites you to put in local resources, legal resources. And on the right, you can see what we did for one of our clinics. That we put in the Resurrection Project, which has immigration consultations, and the NIJC that has a sliding scale model. And so we invite you to do that as well for your clinics. And finally, I just want to talk a little bit about, I won't go into this in detail because the Sanctuary Doctoring Program doesn't have time to talk too much about planning for an emergency, because we're talking about an initial visit. Think about it like when you receive training for breaking bad news for when a patient might be terminally ill. You don't do everything in one sitting. You break the bad news, you schedule a follow-up. This is the same thing. You open the door, you get them started, you hand them some written literature, and then schedule a follow-up appointment. But in this initial contact with them where you've opened the door, just talking about the idea that make sure that they've updated emergency contacts at the child's school or daycare, so that if something were to happen to the parent, the child would be picked up by the appropriate person. So the child doesn't go into foster care or something like that, but that they get picked up by a family member or whomever the parent would want to. If the worst thing happens, say if the family member were detained for a period of time or put into deportation proceedings, the right person could pick them up. And that's at least opened that worst case scenario. So we've begun to see that there is life after any kind of legal action that were to happen if the worst case things happen. But you don't want to go into all that, sort of like in breaking bad news. Once you've broken the bad news, you can't do everything once and people aren't listening, their heads are spinning. So this opens the door about their worst fears, and you've developed the narrative and a way to cope with it after this. And I invite you to continue your professional development. It's not that hard. When you're filling out the Sanctuary Doctoring flyer, you'll get a lot of resources from great people like Laura Hoover, who's following me, but you can do this with Google. When I do workshops around the country with healthcare providers, they're amazed at how much they can find just with the search engine and using words like immigrant rights, attorneys. They can find that out. So they can find these organizations and they'll learn more about who to refer them to locally. And again, there's much great literature. I don't want to overwhelm you with it, but thank you for your time. Thank you.
All right, thank you, Mark. So up next, we have Laura Hoover with a presentation on family preparedness and legal resources.
Okay, I think I got it. Here's the disclosures. A little bit of what we do. This is what we're going to talk about in a really quick, rapid 10 minutes is family preparedness and who kind of needs to be prepared when you're looking, people who are coming into your clinic and kind of the basics on ways that they could be prepared or just ways that that they should kind of be thinking about or preparing for if they're at risk. And then I'm going to give you some resources to find some assistance for your clients, whether you want to have that in your clinic or wherever, if you want to give them specific stuff. Some ways that you can refer them for help, for legal help. So who needs to be prepared? Anybody who's undocumented, that's the obvious one. There's a lot of people in the United States who have removal orders or deportation orders. They've been in court and the judges ordered them removed and they're still here. It's actually more than you would think, and they haven't left. There's individuals with criminal history. So you might have people who have green cards and they have a criminal history, somehow a DUI or something like that. They're at risk for being deported. Individuals working without authorization. And basically the overall thing to know is that anybody who's not a US citizen is at risk of being deported or removed from the United States. One thing specifically to know is you're not necessarily going to be able to, by looking at somebody or necessarily looking at their paperwork, identify who's at risk and who's at not. A lot of people have social security numbers, whether they're valid or invalid. A lot of people do. And for example, even undocumented individuals who are seeking asylum may have a social security number and it's a valid social security number and work authorization, but they're technically undocumented and they're still at risk of being removed. So anybody who's not a US citizen is at risk. The reason it's so important for people to be prepared is a good amount of people can be removed quickly at any time. This was extended under the Trump administration. So if somebody has been here less than 2 years and they can't prove, like ICE picks them up on the street and they can't prove that they've been here less than or more than 2 years, then they could literally just be removed. They can be on a plane that afternoon, and that's happened. So it's super important for people to be prepared, just even when they're walking around and carrying documentation with them. If ICE picks them up and they're not specifically removed, within a few hours, but they're detained in some sort of detention center, a lot of these clients go weeks, days and weeks without any contact to their family. ICE has a practice of kind of shuffling people around. So just know that if somebody's picked up in Chicago, and even though we have an ICE detention center in Chicago, they may be then moved to South Carolina. And while there's this ICE detainee locator and this web address, it's super easy to use. You just have to have the information of the person. ICE does not update that very well. So you could have somebody who's picked up in Chicago, the next day they're moved to South Carolina, and 2 weeks later they're moved to Texas, and it might not show up on the detainee locator for 2 weeks. And so during that time, the family's calling and they don't know where the person is. And so it's very important to be prepared ahead of time. So in documents that people should carry with them, and literally people who are at risk for deportation or removal should carry these with them, birth certificates, passports, these identification utility bills. These are a lot of things to prove that they've been here more than 2 years, because ideally you don't want them to be expeditiously removed. You don't want to put on a plane that afternoon. But all of these are also information, like if they're detained, they could potentially see an attorney while they're in the detention center, and the attorney's going to need this documentation. So it's important for them to carry it around so that if they're detained, and they can assist their attorney while they're detained. This is information that alternate caregivers need to be prepared for. So when the raids happened over the last couple of years, what frequently happened is obviously nobody has any warning, and ICE is going into employers was the big thing. So they would go into a factory that ICE had been working with the IRS and knew that, there's a lot of people there who are undocumented, and they would do a raid and they would pick everyone up. And then children would get out of school that afternoon and nobody would be there to pick up their children. So it's important for every person who's at risk to have an alternate caregiver and to let them know ahead of time before anything happens. You're my alternate. If something happens to me, if you get a call from the school or you get a call from somewhere and I'm not there, you're the person that needs to step up and do it. And so as the previous presenter had talked about, having information updated with the school is the most important thing. A lot of children went into, DCFS was called, and a lot of children went into even just temporary foster care when ICE did these raids around the country, because the schools don't know who else to call, and they have to by law call, we call it DCFS in Illinois, but they have to call DCFS if there's nobody there to pick them up. Daycares if they're not at school, all that kind of same stuff. And then the other thing we recommend when we do consultations is we talk about a standby guardianship form, which I'll talk about more in a little bit. This is the information that the alternate caregiver just needs to have on a piece of paper. And there's some forms, I think, in your materials that people can have, and it's places to fill this information out, and you can give it to your alternate caregiver. But it's that way that person can step in and, act as the guardian, act as mom and dad seamlessly, so the children can receive care. Obviously allergies and things like that are very important, but you'd be surprised I can tell you my in-laws don't know the names of the teachers and, necessarily the school location my kids go to. So all this stuff really needs to be written down for the alternate caregiver, and they need to have it ahead of time so that if they get a call from the school, they can pick up the kids and the next day they know what to do for the children. Okay, and then there's lots of different types of guardianship. So like I said, we recommend doing a specific type of guardianship called standby guardianship, and we do these at our consultations. It's a piece of paper, which I think is in your materials, and if it's not, we can send it around. We have it English on one side and Spanish on another, but we're actually working on translating it to other languages. And so it's a piece of paper that mom and dad and the alternate caregiver can kind of execute now. You don't need to take it to court. It's just a paper to have if something happens. And then if the worst happens and someone's detained by ICE, then they can take that piece of paper to court within 60 days. And it's basically like memorializing the parent's intent that this person be the caregiver of their children. Otherwise, with the parent not there and nobody being able to contact the parent, a judge is going to go, well, how do I know that you are the appropriate person, to be the caregiver? So it's putting that intent in writing. It doesn't require a notary, and the alternate caregiver should have a copy, and then the parent should keep a copy just in case. And there's more information here you can find online on the standby guardianship and other types of guardianship too. And this is the information that's just needed on the standby guardianship form. So it's really easy for people to fill out themselves. They don't need an attorney to do it. You just need the information of the children. And basically the alternate caregiver, everybody signs because the language is already pre-written in the form. So you're just filling it out with the specific information of that family. Okay, so here's some list of organizations. There's a specific funding from the state of Illinois called Access to Justice that was just started. The funding passed in 2019 because Illinois has recognized, this really gaping hole of a need for immigration legal services, specifically to prevent family separation. There's no centralized system. I wish I could tell you there's a number you could call and put in information and people could get connected. There's just not. So these are the organizations in Chicago that receive this funding. So they're free or low cost to clients. And I'm putting together like a spreadsheet, a handout for you all, and it would have the specific cost. So some of them are free, like our information's free. Our services are free, but other ones cost money. Like I know Erie Neighborhood House costs a small amount. So we'll provide that handout for you so that if people are coming in and they need legal, assistance, you can give them that kind of sheet knowing that that it's free or low cost for those people. These are all kind of located in different areas. This is the Chicago one, and in the sheet you're going to get, it also includes outside of Chicago. But people who have immigration issues tend to live in certain communities, just by nature of culture and things like that. So you ideally would want to.
I know. Why did they? Are you going to?
You ideally would want to find an organization that fit kind of the type of clients, the culture of the clients that you're serving and that's close to you, and develop a relationship. Like we receive referrals from specific organizations as they know that that's the type of work we do. And the other confusing thing is there's lots of different types of immigration relief and different ones specialize in different areas. So it's all the more important to kind of figure out what organizations work for you and the type of clients you're having, so you know kind of where to send them. And then one more resource, this is just the American Immigration Lawyers Association. So you can search, especially if somebody has a specific language need. What's really nice about this is you can search by that language. The thing about this is all the attorneys who are members of this organization are on there. So you're probably going to have free and low cost attorneys, but you're also going to have attorneys who are in private practice and cost money. And for example, like if you have a client who's seeking asylum and they need legal representation, I think like the minimum that private attorneys charge is like $6,000. So just know that if you're referring people to this resource, a lot of these people on there will charge money. And I think that's the end of mine. Thank you.
Thank you, Laura. So up next, we have a presentation from Ricardo Cifuentes and Dr. Nahiris Bahamón on institutional policies and protocol.
Good morning, everyone. Does everyone see everyone asks this, but I have to ask myself. Okay, great, I'm getting a thumbs up. So thank you for that. My name is Ricardo Cifuentes. I'm VP of External Affairs at Esperanza Health Centers, and I'm joined by my colleague, Dr. Nahiris Bahamón, who's a pediatrician at our Little Village Clinic. For those who are not familiar with Esperanza, we are a community health center located on the southwest side of Chicago, seeing a largely Latino population and providing services and clinical behavioral health, including pediatrics. So these are our disclosures. We have none to disclose. And this is really what we want to focus on today. So what are the institutional practices and policies that we implement at our clinic and maybe could be copied or modified at your practice to really create a welcoming environment for your patients? And so when we're talking about this, we really are focusing on three of those. One, the physical environment, right? What is it that patients see, feel, experience when they walk into your practice and makes them think that they are in a safe place where they're going to receive the care that they deserve? Another one has to do with what steps are we taking, and you'll see here I've called it welcoming community presence, but what steps are we taking to create that expectation of welcoming healthcare before a patient even steps foot in the clinic? And so we're going to talk a little bit about that. And then the third one has to do with, this is maybe a little bit kind of harder to articulate, but how do we extend that welcoming healthcare expectation beyond patient visits? So when we are connecting them to resources or needs that they may have, how do we guarantee that they're going to encounter the same kind of care and attention with our partners that they do from us? So let's start with our physical environment. And I want to preface this by saying briefly that I acknowledge that there are practices of all types, right? We're a community health center, we're a small organization. I'm looking at the list of people who are here. Some of you are with larger institutions. Some of these may be harder or easier to implement, but I just wanted to give a few ideas of things that we've done. And if there's something that really speaks to you or seems like it could be kind of taken up by your practice, and there's definitely many more. But one of the things, of course, is just making sure that our signage is in the language that our patients are really going to take, it's really going to benefit our patients. In our case, it's Spanish. So a lot of our signage at our clinic, or all our signage at the clinic, is bilingual. The directional signage when you walk in the door, any flyers that you may see, they're always going to be bilingual. In your practice, you may have multiple languages that are spoken. So some of these things may be a little bit more difficult to implement, but there can be, I think, really important ways that you can demonstrate that you have the language capacity to serve our patients in your clinic. We do other things. You'll see in the picture to the left that we commissioned some murals to be on our grounds over the summer. They're a little hard to make out. Some of these address Black Lives Matters movement. We have one mural about immigration and ICE, another one about the importance of voting or being civically engaged. And really just so when people step out of their cars or they're walking down the street and they see this, they know that we are kind of socially justice oriented. And I think this is something that speaks a lot to the kind of care that we hope to provide to our patients. Another thing is the exam rooms or the community rooms in the clinic may have something as simple as just artwork from local landmarks that patients would recognize as being their neighborhood. So really trying to accentuate that feeling of a medical home for them. Waiting room, exam room design, that's something that we were able to do in our new building. Obviously, that may be a little bit less possible if you already have an established place, but just making sure that the rooms are ample enough that we can accommodate multiple family members if they do come into the room, and just, you know, that's essentially the point that I put there. And then this last one, this isn't something that patients can actually see when they walk in the clinic, but we do have a policy on how to respond in the event that immigration were ever to come to the clinic, trying to, you know, do some kind of enforcement activity there. And this does speak to the physical safety of our patients, which is why I included it in this slide. If anything of that nature were ever to occur, at least patients would see how we respond and know that we are committed to their safety and comfort in the clinic. I spoke previously about trying to set the expectation of welcoming healthcare before people even arrive. And that really has to do with our communication. So what tools are we using to convey the commitment that we have to providing a welcoming environment for our patients in the community? So one of them is using social media. Again, our social media is bilingual, but it's more than just the language, it's what we are communicating. So in addition to health, we're talking about policies or positions that we're taking on issues that are important to our patients. We participate in community events and celebrations. Prior to COVID, you know, we were had volunteers march in the Mexican Independence Day parade, for example, since that's a neighborhood that we, the little village and southwest side of Chicago is largely Mexican. So participating in events like that really kind of connect Esperanza to their identity. We work with neighborhood groups to learn a little bit more about what residents of those neighborhoods are caring about and making sure if there's a way that we can address that through our work. The past 4 years have seen any number of assaults on our immigrant population. And so when there have been opportunities, we have also submitted comments to the agencies to make sure that they know where we stand. And then we share these with other community groups or with our patients as well, so they know where we stand. And then the last point there is to really engage with media that our patients consume so they can see us, again, making that connection. I included a slide here. This is partly about social media, but this is also about the materials that we're providing to our patients. And I really want to acknowledge something that my fellow panelists said a few minutes ago about making sure that the materials are really accessible and speak to the needs of the patient. Sometimes in our wish to give them as much information as we can, we end up creating these really dense kind of behemoths of information that are not really navigable. And so maintaining the reading level and just the comprehension of the document in mind and trying to create things that people are really going to benefit from. And this is a continuation of that. We were talking about Know Your Rights information. We created a pocket-sized card that people could put in their wallet and their purse. It's, you know, sometimes giving people flyers. There's tons of flyers people can pick, and they're not really practical. So trying to find more innovative ways to disseminate information that our patients could benefit from. And then I already showed you the fact sheet around public charge rule that I think is included in your documents, but if not, I'll be sure to get it to Tim and Mary later. So with that, I am going to pass it on to my colleague, Dr. Bahamón, and there you go.
Thank you, Ricardo. So from a provider perspective at Esperanza, we understand that a lot of our patients have great needs that are met and that they might not know what resources to go to to meet those needs. So our Esperanza, we have a care coordination department, which is in charge of coordinating care that is medical and also the social needs and legal needs of our patients, and also connecting them to resources. We, as a welcoming healthcare practices, we do not ask about immigration status or country of origin, but we know that many of our patients have issues with immigration and legal issues in general. So when a care team member identifies that there's a need, we connect the patients to our care coordination team. We do not have a universal screening method. We use our own interviews and during our clinical time to identify what needs, and if the patient wants to be connected, we connected with them. For a high risk and complex patients, we do, as an organization, a more in-depth assessment, and then we uncover additional needs, and then we connect them to organizations that can help them. We have really close working relationships with many organizations in the city, such as the ones that you see here, Latinos Progresando, Legal Aid of Chicago, and many more. So we try to connect our patients not only with the healthcare that they need, but also with the resources that they need to deal with other issues that we know affect their day-to-day lives. Thank you very much.
All right, thank you both. And so now we're going to move back to Dr. Giri for our case study. And just a reminder to everyone, after Dr. Giri presents the initial case, we're going to move into an open discussion. So you all will be able to unmute at that point, and then we can just kind of have a free-flowing talk. So with that, Dr. Giri, go ahead.
So let's circle back to Arun. Arun's presenting for his 6th grade physical. He's got a BMI of 91, a PHQ 94. That's a screen for depression, which kind of clocks him around moderate depression. And you notice on exam that he's gained some weight since the last time you saw him. You also realize, looking at him, that his affect is a little flat. You ask about his summer, and Arun reports that his summer was kind of boring. He was mostly at home playing video games. His mom admits that his dad's been back home fixing his papers, and mom's been working really long hours at the restaurant. She feels a little guilty about that. And she's also still paying off what she calls the money she owes for coming here. So then you proceed back to Arun and ask to clarify some of the answers from his PHQ-9 questionnaire. And he tells you that he wasn't really sure about some of the answers. Or some of the questions he didn't understand about sleep and being tired. And mom also reports that she tried to help him fill out the questionnaire and really didn't think that that question about suicide was necessary or appropriate. You then try to ask to see Arun alone to interview him in more private setting. And mom insists that this is definitely not necessary. She's a bit taken aback. Arun tells me everything. I'm his mother. And so you decide not to push the issue, recognizing that this could be cultural and possibly exactly as your own parents would have responded to that request. So you switch topics again and ask Arun if he's looking forward to going back to school. Oh, shoot. And, oh man, sorry. You ask him if he's looking forward to going back to school. I keep doing the same thing. And basically he tells you that he hasn't really made a lot of friends there, and there aren't that many Indians in his school. He gets teased a lot about his accent, and kids are always telling him to go back home. His mom puts up her hand stating, you have to be strong and not listen to them. What else can you do? And so based on our presentation today, how would you begin? We'd like to hear from you about what steps you would think about taking next. feel free to chime in. Tim, everyone's still muted.
Yeah, they should have the ability to unmute themselves.
So would any of our speakers like to jump in with comments on the case?
I'll start. The thing that jumps out at me about the case is that normally the hardest thing to do if one wants to address immigration-related stressors is to get started. And there are several opportunities in this particular case that give the physician a chance to open that door. And probably you're going to run out of time before you get very far with it, but at least to say to the mother that it seems that Arun has several things going on, potentially depression. I mean, you want to explore some causes, and that she's mentioned the father working on his papers and her own debt from travel, and that it is possible that there are some stressors related to immigration that are infecting the patient, and to give her some material and schedule a follow-up appointment. One may not be able to get very far in that initial appointment, but at least to open the door, there are some cues that have been given.
I think that you're absolutely right to plant the seed. And I think I also might start just by thanking both of them for sharing what they shared, and acknowledging that it sounds like they're both having some challenges, and that the doctor's office may be a place where we can support them around those challenges.
I also want to add that it's very important to ask the questions from the standpoint that I want to learn more about you so I can help you better, as opposed to, I think you have depression, I think your son is doing this or has that. So maybe asking questions like, how would you like me to help you? What do you envision my role to be in helping you and your son moving forward? So it's all about that, creating that trust, first of all, and because if we do build that, eventually, like, we'll be able we'll be able to speak about the immigration, status, more ease afterwards. So it's all about building that connection, I think, in how we ask the questions.
One of the things when I first thought about this case was that there were so many things going on. There's this weight issue, and maybe that's tied to some mood things that are going on. And then, of course, the mood things seem to be linked to a couple different factors. And one is this immigration situation, but then also the way he's being treated in school. And so, and that's a tough one. It's again, speaking to isolation, to this bullying, and his mom doesn't really seem to have the resources or kind of mindset to know how to really take it in and listen to him and maybe give him what he needs. She's very overwhelmed, it sounds like, and like the last thing she needs is to, listen to him complaining about friends at school. That's really not a priority for her. And so thinking about ways to support Arun and suggestions to make, one of the things I've encountered is just thinking what are strengths that he has that could help him connect to other kids. Think about like sports or some kind of after school activity, asking him about his interests and seeing if there's something he can engage in that would help him connect to other kids with similar, interests and like-minded interests. And the other thing is I always provide a letter for the parents around bullying, because there are Illinois state laws about bullying. And so if the school is aware, by law, they're required to address the situation. And this can be slippery because obviously he can encounter more stigma if people are trying to intervene, adults are trying to intervene on his behalf. But the school still has some responsibility for creating a safe and kinder environment in the school setting. What do people think about that, about the bullying? Do you see that in your practices?
This is Nahiris Bahamón. This is a great case. I think this is a very common situation and combination of factors in many of our patients and families. One of the things that I will particularly be very worried about is, the concern for depression and the effects of that. We know that, depression, especially during these times, has increased, and there's a real risk of harm and potential death for patients and teenagers that are depressed. So I will be concerned about this and make sure that we offer resources such as behavioral health counseling. We are very lucky that we have behavioral health counseling in our practice, and we can do our easy handoff. But this will be one of my main concerns during this meeting, and then trying to build a rapport and that trust so the family feels comfortable in our space and during our visits, so they can come again and we can start to tackle many of the issues.
So I just want to jump in and add, there's so many things going on. And I think, as Mark mentioned earlier, that follow-up is key, bringing patients back. They're not going to come back if they don't feel comfortable with you. But if you can find ways to bring them back and, create that relationship and tease more out and be able to really connect them with the resources they need. And that's as providers. It is 9:31. So we want to be respectful of your time and not run over. If anyone has additional questions, please feel free to forward them to me or Mary. And we look forward to touching base with you after the second webinar. We haven't scheduled that yet, so we'll be sending out a notice once that's set up. And if there's no other questions, then thank you so much. See everyone later. Go enjoy the inauguration to make sure that the country's not burning down.
Thank you.
Thank you.